Hello and welcome to The Path, the podcast from LifestyleRx. As always, my name is Dan, and joining me today is Byrne. How are you doing?
Awesome, Dan.
And today we have a special guest, Dr. Tom Elliott. So Dr. Tom Elliott is an endocrinologist and the medical director of BC Diabetes, which is an innovative practice exclusively focused on diabetes in BC. And he's recently joined LifestyleRx as our endocrinology medical director. So nice to have you here today, Tom.
It's great to be on, Dan. I'm looking forward to it.
Yeah, so nice to have you join LifestyleRx and get you on the podcast and be able to chat about this.
Brendan, I've been looking forward to working with you for years, and I'm so glad it's come to pass.
I know. I think we're going to have some fun. Why don't we start by having you share a little bit with our listeners just about BC diabetes, because it's a different concept than a lot of practices, and it's something that I think has brought a lot of great care to many more people than if you'd kind of gone down the conventional path.
Yeah, I've never done anything conventionally, Brendan, and it is something that has evolved in a way that I'm proud of. I'm an Aussie endocrinologist. I'm a straight talking kind of guy, and I like to bring to my clients with diabetes what I've learned through experience and the literature. And I'm an innovator. I've always gone with what I think is the best treatments and the treatments that are developing. I've had some faithful staff over the years. I've been an endocrinologist for 31 years. I guess I branded it as BC Diabetes about 15 years ago, and we've now got 18 staff, and we're a full service diabetes clinic. Dan, you said we're in BC. Yeah, we also operate across Canada. So the virtual care that exploded with COVID has allowed us now to treat people all the way across Canada. So we do pediatrics, we do adult diabetes. We have access to all the medications that your listeners will be aware of. Plus, we do clinical trials, which gives us access to experimental drugs and devices, and that's very exciting because they're always out years ahead. And I try to make sure I pick the winners. Occasionally, we have one that doesn't help, and I've never had one that hurt, fortunately. So we've got a staff of 18, 5 endocrinologists. I'm the director, and we run a very busy clinic Monday to Friday from 9 to 5. And it's grown rapidly, and I've realized that there are some things that we probably can't do as well as you've been doing, Brendan, and I think that's why we've joined forces.
Yeah. That's awesome.
Sure. So I've seen you on the news a couple of times talking about what you call the diabetes revolution. Can you maybe explain a little bit about what that is?
Yeah, it's become cliche to my listeners, but perhaps not to yours, Dan. So let me say, revolution is when dramatic things happen and the old ways are tossed aside. So the diabetes revolution has been underway for 5 years, I would say. It started with continuous glucose monitors, which suddenly gave us real-time access, not just in person, but virtual access to blood sugar values. That meant that we could drill down on exactly what needed to happen. In diabetes, you've got to fix the sugar. You've got to manage blood pressure and cholesterol and get your eyes checked and feet checked and all the rest of it. But ultimately, it's fixing sugar. And so with CGM came a sudden understanding that not only do we have this revolutionary device that we'll call a continuous glucose monitor, and that includes other things like automated insulin delivery, smart pumps that maintain your sugar the same way cruise control keeps your car going at the same speed. So we have that in diabetes. But it stunningly made it clear to not just patients but doctors that diet's important. Diet's not just important, it's all important. And until the revolution, I'd kind of paid lip service to it. I'm ashamed to admit it, but we just didn't take it seriously enough. So suddenly we've got diet, we've got other strategies that Brendan knows all about, the lifestyle strategies, and then we've got new drugs as well. So the revolution is drugs that your listeners, Dan, would know about, like Ozempic, a drug that safely lowers weight and sugar. We've never had that. Well, there's a pill. There's a class of pills called the SGLT2 inhibitors that also do it, but Ozempic and related drugs take it to the next level. And then we've got experimental drugs. There's not a week goes by without something new and exciting coming up. There's a drug from a company in Silicon Valley called Biomea, BMF-219. They've got this drug that was originally studied for cancer, and it's very effective for various cancers, blood cancers, but it causes beta cell growth in rats. Dan, beta cells are what make insulin, and the reason you get diabetes ultimately is you don't make enough insulin. In type 2 diabetes, it's because of getting older mostly. Type 1 diabetes, it's the immune destruction. But anyway, so this Biomea drug looks like, in rats, it regenerates beta cells. And imagine if we could do that in humans. So that's what gets me up in the morning. And that's the diabetes revolution in a nutshell.
Yeah, that is particularly exciting because one of our listeners are getting they're getting used to me talking about subtypes of type 2 diabetes, and there are 5 subtypes that we're seeing, kind of really phenotypes, but subtypes that have emerged. 2 of them are the insulin, where insulin deficiency is the issue, and the other 3 is where insulin resistance. And I think that you kind of covered the ground. So clearly these GLP-1s and SGLT2s, they're actually aligned with helping reverse insulin resistance, especially with weight loss. But if we can actually have something that can help pick up the pancreas when the pancreas is deficient, that becomes kind of completes the run on this. And then kind of, as you said, the CGMs. It's amazing what immediate feedback does to our behaviors, isn't it? How do you use them at BC Diabetes? Does everybody coming through the door get a CGM? How do you kind of work with that?
Well, the way it's evolved, we've got good relationships with the manufacturers, so we get a lot of samples, and they have coupons, and then we have people who pay for them, and so everybody gets a CGM. They walk in the door, and I tell them, Dan, about the diabetes revolution. I said, you know what? Things have changed, and ultimately you're in control here. You've come to us for advice. My advice is wear this device that's going to give you a sugar value every 5 minutes for 10 or 14 days, and see if you could correlate the blood sugar values with what you eat or what you don't eat, with what you do in terms of exercise or don't do. And also with when you're emotional or psychologically upset or sick, your sugar will go high. Of course, there's not much you can do about that. But, I would say, Dan and Brendan, that 70% of people say yes immediately. The other 20% are reluctant. And I say, well, you know what? It's not only is it going to, but possibly give you some clues as to about, I can tell you to eat less and exercise more and avoid carbs and white food. But if you discover for yourself that it works, you're more likely to do it. So it's number one, a behavior modification tool for you. And if they still push back and say, there's no way I'm wearing this thing, I don't like drugs and devices, I'd say, well, you've taken the trouble to come and see me, the expert, or one of the other endocrinologists in my clinic. The values we get from this device are going to change. They're going to make us better doctors. We're going to be better able to treat you. So with that comment, we're up to about 99%. So basically everybody wears one, and everybody comes back shaking their head going, why didn't I do this months or years ago? So it's a great opener. It gets buy-in, and basically it drives everything we do.
Yeah, it's fascinating. There's so much information. So there's kind of the obvious where you eat something carby and you get the spike and you realize that, okay, that's probably not helpful. There's the I know I should exercise after dinner, but when you actually see your blood sugars come down, I think it reinforces a lot. The one on stress, I can't tell you in our groups how many times people will it's just an eye opener for them as to, oh my goodness, this is an issue, right? Because I get stressed a lot, and look what happens to my sugars when I get stressed. We shared a bunch of case studies a few episodes back, and one of them was brilliant because the curve during the day was flat, and at night it was going up, and then you kind of go back in the history, and basically the bladder issues were waking this fellow up. You could really see it from the CGM. So lots of feedback there. One of the things I think we're really interested in with the CGMs, kind of putting our innovator hats on, and I know you've done a little bit of work with this, is there's a lot more data in that these devices are spitting out than patients can appreciate just looking at them, or even physicians just looking at the curves. We're really excited about actually getting that data into our platform, and then as the reversal process is happening, as insulin resistance is lessening, we know that as the curves change, you're going to be able to pick that up. The other thing that I think you're going to see is we know that in some patients that with type 2 diabetes, as they achieve remission, that first phase of insulin release actually picks up, and I bet you can see that on the CGM. I bet you can kind of identify that in the first 30 minutes, post meal, that something's changing there. So I think that's going to be fun to work with. You've incorporated this already into your electronic record, and tell me a little bit about that.
Well, okay, I realized that I didn't fully define the diabetes revolution. There were a couple of other bits, and you've prompted me, Brendan. Thanks. So there's a free utility available called Night Scout, one word. And you can build it for free yourself. It takes about 8 hours if you know what you're doing. Or you could just come to BC Diabetes and you get one for free. And no doubt LifestyleRx people will also be getting one for free, Brendan. But this allows you to share your data with anyone. And in the case of the electronic medical record at BC Diabetes, it comes into the back of our EMR, so that the CGM is part of everybody's patient record. And yes, Brendan, it teaches you stuff that's obvious, like eating, a foot long and
drinking a 32-ounce Coke.
Yeah, exactly. Or the nuances where you see the restoration of first phase insulin. For the listeners, that's it's the first thing that's lost in diabetes, and it's subtle. It was subtle in the pre-CGM days. Now it's not subtle. So we see it coming back. The other thing the other part of the revolution that I didn't really define, Brendan, and I've only really started talking about it, is diabetes remission and reversal. I've been an innovator all my life, but I've also been a skeptic, and I wanted to be careful not to jump on something that I thought was uncertain. But the diabetes reversal story, let's call it remission, making it go away. Reversal means it never comes back. but certainly diabetes remission is not just possible; it's probable if you do it right.
Yeah.
We talked about rats and this Biomea drug, but I'm sure your listeners know, Brendan and Dan, that if you starve rats and then allow them to feed again, that they get restoration of some of their beta cell function. So we think that some kind of shocks to the system cause beta cell regrowth. And so I look forward to learning more about LifestyleRx, Brendan, and how you cover off those kind of rat discussions with your clients. But if you're listening and you've got diabetes, not only if you want to control your diabetes, then you just need to talk to one of the LifestyleRx doctors. They'll talk to your GP. If combined they can't figure it out, they'll send you to someone like me. If you can afford the drugs and devices, then you will get control. And if you're able to achieve a good level of physical fitness and a target body weight with the necessary exercise, there's a really good chance of your diabetes going away, diabetes remission.
Yeah, it's interesting. I think when I look at the data, I think that upwards of 50% of type 2 diabetes remission is possible. And obviously, getting people earlier or closer to the diagnosis seems to make a difference. In the kind of the literature, I think they say within 6 years, usually you see restoration. After 6 years, it's a bit of a wild card. But just so we're clear, remission we uses the language of getting your blood sugars out of the diabetic range, and right now in Canada we use kind of getting it into the less than 6.5 on the A1C, and technically remission is off medication. We use reversal more as the process, not necessarily the destination. Remission's a destination. Getting rid of insulin resistance is a destination. Reversal is really the process of this, and because what we really try to emphasize to people is look, it can go both ways, right? And a lot of people, and I'm sure you saw it in your practice, but the pandemic was really tough for a lot of people. That they certainly progressed with their insulin resistance, and their diabetes got worse during the pandemic. And so kind of letting people know that there's a lot that they control over the degree of that insulin resistance and kind of the reversal of that insulin resistance. And that, good many, I think at least 50%, and maybe, with this pipeline of other kind of tools in our toolkit, we start pushing it to 60 or 70% of people can achieve that remission. It's pretty exciting.
And Brendan, before CGM, I don't know if you remember the bad old days before CGM, but we just completely underestimated the benefits of lifestyle.
Right.
I saw a patient a couple of weeks ago who came from somebody else, another clinic, and he was on 400 units of insulin a day without very good control. At our clinic, our case managers give everybody a rating on a scale of 1 to 10 for how low how low their diet is in rapid carbs, low GI carbs. A score from 1 to 10. 10 means you basically don't eat carbs at all. 1 means you live at McDonald's. Anyway, they gave this guy a rating of 6, which is not bad. It's not very good, but it's not very bad. And so based on that rating, we kind of extrapolate, we predict how well they're going to do. Anyway, he went from 400 units a day with bad control down to 50 units a day with good control. So, clearly we need a better scale of predicting how people are going to do. Brendan, I know that's something you do at LifestyleRx. How do you do that?
So what we do is we have a whole series of patient questionnaires which we can evaluate kind of diet habits, exercise habits, sleep habits, stress resilience habits, as well as a whole bunch of symptom categories. And then we pair that with blood work. So we actually kind of look at what you're doing, so behaviors, how you're feeling, symptoms, and then we look at the biomarkers. And the key thing that we found up front is really helpful is doing kind of the HOMA-IR2, which is basically we measure a C-peptide, so kind of the protein that cleaves off of insulin. We'll measure that in a fasting glucose and plug it into a formula that's the team at Oxford figured out. It's a nonlinear equation, but it gives us kind of at rest, kind of what the beta cell percentage is, how hard the pancreas is working. And it gives us an insulin resistance number. And so we're able to see from that, if this is an insulin resistance number and the pancreas is compensating, but not compensating well enough, then you can extrapolate. If you can get rid of the insulin resistance, you've got enough beta cell function to actually have normal blood sugars. And this is kind of, I think, one of the key moments kind of when people come into our program, because for the first time, somebody's talking about why, like, why is this happening to me? And the linkage, so we create that linkage between there's this insulin resistance problem, which usually correlates to fat in the liver. And, oh, look, your fatty liver index is high. And that usually correlates to, having visceral fat and your waist circumference is high. And generally you get, visceral fat when you cross your personal fat threshold. And let's look at, kind of where your BMI is. So putting these pieces together and kind of linking them, I think is really helps people understand, why this is happening. And then the what to do becomes what we teach them, right? So we start to work through in the program around, okay, how what is it that you can do? And then finally in the group stuff online with people, it becomes, okay, that's all well and good, but how the heck am I going to do that in my life? I can see how you can do it in your life. I'm not sure how I can do it in my life. And that's kind of where people help people. And we get, I think a lot of the magic happens is in those groups. Now, Tom, when, we've kind of crossed paths a number of times, and you probably don't remember this, but it was back in about 2017 or 2018. And it was, we were on a panel, and I think we chatted afterwards, and I talked a little bit about kind of the emerging stuff around diabetes reversal and the Roy Taylor work, and also Sarah Hallberg's work from Verda. And you weren't sure yet. And I remember kind of you were like, yeah, because it was 2018, it was new. Yeah. We hadn't really, I don't think in that time, when did you start using CGMs?
About then, 5 years. Yeah.
It's probably all percolating at the same time that.
Yeah, I guess I just hadn't seen these, quantum steps with lowering of sugar with intervention. No, you know what? I'm the first to acknowledge I didn't get onto that one quickly as quickly as I should have.
I think what's fascinating though is I don't think I'm not saying it to throw you under the bus. I don't think anybody did, right? Like I think there was a series of things that happened around the same time that I think, if we look at this diabetes revolution, those two papers, the direct study and Sarah Hallberg's work with at Indiana, those were really interesting because two very different dietary mechanisms, one very low calorie, one very low carb. So two very different dietary mechanisms with similar levels of remission at the same time that the CGMs were starting to become available. And then the thing that I think really plugged me into it, because that's when I started paying attention to it, was also just kind of people on the internet and on Twitter and things, very credible people, often engineers and things like this that just were doing things on their own and showing kind of their own results. And you're kind of going, this is interesting.
Yeah. It's part of the information revolution is, right. It's been at the same time. Yeah. By the way, I think your spiel about the why question, Brendan, should be incorporated into my list of diabetes revolutionary changes. Because understand, as soon as people understand why, it's the biggest resistance to acceptance has gone.
Well, it's kind of funny because I liked how you said you're kind of an Aussie straight shooter, and I'm Irish in background, and like so you tell an Irishman or an Aussie to do something without telling them why. Not going to happen, right? And I think for our patients, it's that way, right? It's how do we really expect them to follow this strategy that takes work if they don't really understand why?
And Brendan, why do I like Brendan? He's an innovator. He's done lots of stuff, and he has shown me that that what we're talking about applied to individuals can be scaled to our entire society and nation and continent and world. Like the potential for what these relatively simple changes can be towards a profound improvement of the nation's health is so great. I can't wait to do it and see how we can bring it to everybody, Brendan.
Yeah. That was kind of the silver lining of COVID for me, was when we went online and realized that, wait a second, if we're interacting with people online, we can reach people anywhere. And the knock on lifestyle medicine, and I think why a lot of people don't do it, or kind of don't think it's very feasible, is just that it takes a lot of time. And if you're having to explain the same things over and over again, and it just financially doesn't work for practices. They just can't. You can't spend an hour with every patient. What we found kind of as we built this, and it was kind of during COVID when I first realized, if we're talking like this through a computer, then I don't have to explain in real time insulin resistance, because I can do a really good job of it once, and it's a video, and you can watch it on your own time. And you can stop it and replay it, and you don't have to feel kind of silly about kind of playing something twice, and you can really learn it. And so we find across our initial 12-week program, there is an hour of one-on-one physician time, but there's now 30 to 40 hours of program time between kind of the online curriculum and the group medical, and that's enough time for people to actually learn why, learn what to do, and then finally, kind of figure out how to do it in the context of their lives.
And then, to get back on the CGM hobby horse, they're wearing a CGM at home, and they see immediately what happened.
Right.
They can do a series of experiments. It's quite profound.
Yeah.
So the curriculum, really, you've got the 30 hours of whatever it is on your website, Brendan, and then you've got however many meals there are in 14 days, 3 14s, what's it? 54. 54 meals and snacks and opportunities to change the way they do things.
Yeah. It's funny because we when we were getting the samples, we usually tell people to use them in week 5, because in week 5 we have, our theme is all carbs aren't created equally. And so week 1 we talked about the red light carbs, the sugar, the flour, the white stuff. But week 5 we reintroduce the carbs, and we talk about green light carbs, kind of the carbs that you can have as many as you like, and then the yellow light carbs, which are our good foods that kind of the whole grains, where they're good foods. There's lots of health benefits to eating them, but if you're somebody with diabetes, your portion is really hard to figure out, because it depends on your pancreas, right? And you have no feedback unless you wear a CGM. But even when we teach it like that, there's always somebody that will go buy a milkshake or something just to test, what'll happen. And when I'm looking at these tracings, there's this enormous spike, Dan, on the tracing from the milkshake or whatever it was.
Yeah.
And I said, "What was that?" And they go, "Oh yeah, doctor, I can't believe I did that." And sometimes it's not that obvious. I don't have diabetes, but I wear a CGM every so often just to, it's a new model or something. Anyway, I had a burrito and some nacho chips, and it took me above 10. If it had got me to 11.1 twice, I would have had diabetes. So, I mean, I'm 65 and I'm probably close to that fat threshold that Brendan just talked about. I'm on the edge, and it's just a reminder of just, come on, Tom.
Yeah.
Practice what you preach. So,
well, it's something that I love about lifestyle medicine is we're all in the same boat, right? We all have to actually eat well and exercise and manage our sleep and stress and all that. And so I always feel with people, it's, we are teaching things, but it's not like, it's not like it's easy for any of us, right? And so we're all working at some level on these things, and there's no shame needing help, right? Because there's lots of things that each of us can improve on, and it's kind of like everything. We have our strengths, and then we have some of our weaknesses, and it's just that's what's kind of fun about it, is you kind of look at it, and just like you said, you kind of feel like, oh geez, I better get onto this. I will have that where I'm working all day, and then I do run a group, and it's about exercise and sedentary behavior, and I'm like, oh my goodness, okay, tomorrow that rower in my office is going to get some use.
Yeah. So just to get back, you talked about Ozempic and the other GLP-1 drugs briefly a while ago there, but how do you think, like, as an endocrinologist, these drugs have kind of changed the game in terms of diabetes management?
they're the second drug that lowers weight and sugar safely. So previously we had drugs that lowered weight that caused heart problems and psychiatric problems, and so I never prescribed those, and I'm glad. And the people that did don't anymore. So we had drugs that were effective. They're still kind of expensive, but they've gone on to most. I think they're on the provincial formularies of every province now, so that at some level you're going to be covered for these drugs. We use them early. I think historically I haven't paid enough attention to lifestyle, and that's why I've joined forces. Well, Brendan thinks he's getting a great deal bringing me on. I think I'm getting a great deal being involved with LifestyleRx because it's complementary. It's different. It's not really what we do. So Dan, we use these drugs early. We emphasize that lifestyle treatment comes first, and lifestyle treatment is forever. I mean, you can cheat and miss and not do as well as you might, but ultimately that therapy is going to be there forever. And then we add these GLP-1 drugs. Now they've evolved as well. So the first GLP-1 receptor agonist came out, I think 12 or 13 years ago. It was called exenatide, and then we've had various iterations. We had Victoza, and then for the last 4 or 5 years we've had Ozempic. Ozempic is about to be overtaken by a drug called Mounjaro from Eli Lilly, and the recent supply chain problems were like a gift to Mounjaro. So Mounjaro is going to get used, and then each of these drug companies is developing better drugs. So how do they get better? Number one, they realized they were too cautious in the dosing originally. So you could actually give a whole lot more of these drugs, and they continue to work well without much increase in toxicity. And then they've developed drugs that have not just 1, but 2 and 3 receptors that they work on. So the benefits become multiplicative. Yeah. So how do we use them? We tell the patient that, if you take Ozempic, for instance, it's going to suppress your appetite. So if you're the sort of person that couldn't walk past a Christmas buffet without, trying everything twice, now you might just walk past it completely. You just lose interest in food. Secondly, it delays the emptying of the stomach. So when you've eaten, you feel full for longer. And then finally, the the reason that it helps the sugar numbers so well is that it helps your insulin cells, your beta cells make more insulin. That's called the incretin effect. So those are the three mechanisms by which they work. And we tell patients that whatever weight you lose with Ozempic or Mounjaro, if you stop the drug and revert to your former, behaviors, primarily eating behaviors, your weight's going to just rocket straight back up there. So I'm sure Brendan has thought a whole lot more about what you do when you decide to stop these drugs. But Brendan, why don't you tell me what do you do with your clients when it's time to come off the GLP-1?
So we generally like to start first, and I think you touched on that, and this is where I think that we will be so complementary to you. Just I do think lifestyle first it makes a ton of sense, because if you don't change the lifestyle, then the data is very clear. As soon as you stop the drug, the weight will return. Worse than that, 40%, at least on the studies that we have DEXA data on, actually have just data around muscle and lean mass. 40% of the weight loss is actually lean mass weight loss, and a good portion of that is muscle. And so you kind of can imagine when you lose that, you're not going to regain that. Like you're going to regain fat. So the danger, I think, with the drugs is just that, if we don't tackle lifestyle first, then we may be setting people up for for this regain of weight, but actually loss of muscle. So we're really big on, okay, let's kind of work on some of the, if you look at what these drugs do, they basically mimic our satiation hormones. And I always like to explain to people, like, you need to know when to stop eating. That comes from at least 11 different hormones plus stomach stretch receptors struggling to get a signal back to the brain to tell you to stop, right? Wow. Ultra processed foods, the dominant food, more than 50% of the calories in Canadian diet are ultra processed foods, which simply don't send the same signal. So if you're eating those foods, you're eating foods that your body can't actually send the right signal for, right? So you eat 1,000 calories, your body thinks you ate 400, right? Your brain kind of keeping track of it. So if you don't change that first, you're kind of setting yourself up, I think. And so kind of making some of these changes and doing the lifestyle program first is, I think, is really helpful. What's so hopeful about the GLP-1s is some of our patients go through and they don't ever need a GLP-1. The change of lifestyle is profound enough. They come underneath their target weight, their insulin resistance goes away, and so they can achieve remission without. Some people have so much insulin resistance, it's really, really hard for them to lose weight. And these drugs are so hopeful because they get the snowball rolling, and they get it started. And so then I think the two together, kind of when necessary, becomes important. And then what we try to do is kind of lowest effective dose for the shortest duration. And we try to have an exit strategy up front. And that really is kind of, when you start these drugs, you taper them up slowly because of side effects. We taper them back slowly just because, if you think about withdrawing that extra satiation effect, you want to give yourself time to see what happens. And everything we do is about the long term, right? Like we're interested in long-term health. So it doesn't make a difference if you're going to be on the, you're eager to get off the drug, but does it really make a difference if it takes you 6 months to come off the drug slowly, but you come off of it in a way that minimizes any weight gain? So that's kind of how we approach it. And we have lots of people that come to us on GLP-1s. And what's interesting, and maybe it's the selection factor with our program, a lot of people want to come off of them. What we find is most people are quite eager to get off of medications, not because I think they just don't want to be on medications. And so part of our job is really trying to help them understand which medications they can come off of. And then sometimes it's, cases of, this drug may be doing something that's good for your kidneys or heart, and it's worth staying on, and maybe you can be on a lower dose, or we can find something that doesn't give you side effects that you can get that extra bit of benefit from.
I love that, Brendan. It reminds me, Dan, of another nuance of the diabetes revolution. When you go to medical, most people think that if you double the dose of a drug, you get twice the effect. Well, the fact is you don't. You get reducing returns. So the opposite part of that is if you reduce the drug by 50% or 75%, if you reduce it by 50%, you probably still get 80% of the benefit. If you reduce it to 25%, you're still probably getting 60% of the benefit. So we talk about micro dosing now with drugs like GLP-1s. The Ozempic pen, a full dose of Ozempic is 76 clicks. That's 1 milligram. So we often dose it in clicks, 5 clicks, 10 clicks, 20 clicks. And patients can find a dose that provides the satiation, that tells you that you've had enough, but allows them to enjoy food at a dramatically reduced cost.
Right.
So yeah, it's the diabetes revolution.
So I think this has been great, Tom, and welcome to LifestyleRx. I think for our patients, I think it's the best of both worlds, right? So it's lifestyle and it's medicine, and I think together, more people can achieve remission. I think more people can prevent diabetes. We get a lot. You probably don't see these patients as much because they're pre-diabetic. So we see a lot of pre-diabetics. So preventing diabetes is very important. And then I think also as well, it's just being sure that like people don't, they can avoid the risk of the complications, right, and avoid suffering from them. And I think those three things done together, the remission, the prevention, and the avoidance of complications. It involves both parts of it, the lifestyle and the medicine. And so I'm just very keen to kind of put our experiences together because I think they're so complementary and there's so much that we're going to learn from you. So I look forward to working with you.
Well, likewise, Brendan, I can't wait to work. Well, we started already and to take it to the next level together.
That's awesome.
Awesome. Okay, well, I think we're just about out of time for today. So thank you to both Tom and Brendan for joining us today. That was an excellent discussion. I really enjoyed it. And for all listeners, if you know anyone else that would benefit from, listen to this or find it interesting, please do share the podcast with them and let them know about it. And finally, as always, if you'd like to join the LifestyleRx program, it's available. It's provincially covered in BC, Alberta, and Ontario, and you can find out more at lifestylerx.ca. So thank you once again, Tom and Brendan. It was great having you here, and we will talk to you soon.